Excellent.
Try and
Okay.
share.
Wonderful. So for those of you just joining in, those of us just joining in, I've just checked in. Here I am. We are running a mock membership oral exam this morning. So Josh has got a couple of questions and I've got a couple of questions. The actual oral exam, I think you will actually have more time than we've got in our hour session today. So we will sort of like push you for answers a little bit. If anybody would like to answer, I think this tool is probably the best one. Oh, no, because we won't be able to see you because we're sharing screen. So just say your name maybe and we'll go to you. Is that all right? Excellent. And anybody that doesn't want to answer any questions, stay silent and we won't target you specifically. All right, go for it, Josh.
Okie doke. 1 sec. Can everyone see this?
Yeah.
Yeah, okay. I think last time at this point we kind of briefly spoke about what it kind of looks like. So one thing I will always say is your examiners are not good. They will not be very personable during this experience. So it can be a bit off-putting. So just pretend they're not there really, I think, and pretend they're a computer because they kind of act like it. Even if you know who they are and they're nice people, normally they're not those people. It's a bit odd. So the other thing as well is you can ask them questions and for more information, and they'll flat out say you have everything you need. If they don't want to give you anything, they have to be quite careful. That's not to say there's anything else that they will give you, but if for some reason something weird about the question you don't quite understand, just ask. I think that's kind of the main things. So, and also, as Anna said, they might prompt you for more, and that's usually a hint to kind of keep talking. And there's no kind of limit. You can go for as long as you feel comfortable. And if they don't ask for more, then you're probably doing all right. Okay, so let's start. So the first case we're going to do, so one last thing, bring a pen and paper because I didn't when I did mine, and you don't get these on the screen so that you won't have text on the screen. They'll just start talking and you have to jot things down as you kind of go. So this is a bit different. All right, so case one, a 10-year-old male neutered domestic short hair presents with inappetence and lethargy. You do not notice anything out of the ordinary on physical examination. You perform a CBC in biochemistry as part of your initial investigation. We've provided you with the CBC and biochemistry findings. List your problem list for this patient.
Say your name, say your name. Sorry.
Jalal, I'll have a go.
Yeah.
So the hematocrit's 24 and looks like it's normocytic, normochromic. So it'd be like a mild non-regenerative anemia. There's elevated glucose, hypoglycemia, creatinine's markedly elevated. So is the urea, and we have hyperphosphatemia. Total protein is elevated marginally, and albumin is also moderately elevated, mildly elevated. And potassium is 5, so it's very mildly elevated as well.
Anything else you'd like to add?
So the problem list would be mild non-regenerative anemia. We don't know if it's so we're azotemic, but we don't know at this stage if it's renal or not because we need to see a USG. The elevation in total protein and albumin could be due to dehydration, especially if the cat's been inappetent for the past few days. We don't know if it's been drinking a lot either. And the phosphorus is elevated quite markedly, and that would lead me more towards thinking that it's a renal azotemia. And with the mild elevation in potassium as well, That's concerning, especially if the cat hasn't been eating. That would make me think there could be a renal problem going on. It's possible it's post-renal as well, and we would need more information to determine that.
And the
Yeah.
lymphopenia too.
More than I'm missing? Oh, sorry, I didn't see that. Yeah.
It's hidden well.
Yeah.
Nothing found on clinical exam, so there wasn't a full bladder.
Inappetence and lethargy is part of the problem list.
Yeah. So inappetence and lethargy.
Yeah. You're allowed to also ask the examiner to go back and forth between slides or things as well, if you wanted to kind of reassess something again. Good. Okay. Yeah, you might get one of these questions. They're quite good at, these are quite easy marks in a way, because you just list everything. You never get marks for saying, you never get deducted marks for saying more. But in this scenario, you wouldn't have to assess the problems, you just need to list them. So, but that's all very, you've got everything there, so good. List 3 additional diagnostic tests you would recommend for this patient.
I can go.
Yeah.
So urinalysis, ideally cystocentesis sample, abdominal ultrasound, and blood gas.
Great. Yeah.
If it's just list, do I have to justify them or?
No, just list this one. They might ask you to justify it, but in this one, just list. So in this patient, you requested an abdominal ultrasound, urinalysis, and urine culture. This is your ultrasound report and one image from the ultrasound. In this scenario, you may just get the image and they may say to describe it. You might just get the report, but I'll give you both. So have a read and I'll move across in a second. This is your urinalysis. And the urine culture is still pending. What is your primary treatment recommendation for this patient, and what is your ongoing management plan? Briefly justify your decision and each recommendation.
Wants to provide some pain relief. He's probably pretty unhappy given he's got a uterine leak, and you'd be looking at doing like a SUP. I think it's called subcutaneous urethral bypass or a stent to relieve pressure. Start.
Yeah, good. Anything else you would do as part of management for this patient?
I'd start him on some
Ongoing
IV
management,
fluids.
sorry.
Yeah, I'd start him on some IV fluids. I'd be checking that potassium probably in 6 hours, see if it's gone down. I'm sure it probably will because it is quite a mild one once you fluid diurese it. And you'd be monitoring probably his glucose. It's a bit high, but it hasn't eaten for a while, so I'd be worried that it might normalise and actually be a bit low. You'd also possibly, once he's through the surgery, sub placement, you'd possibly consider placing a feeding tube at the same time, depending how long he has been on food, in case he does take a while to come back to eating. So you don't want to hyperlipidose as secondary. So I think at the moment.
Right. Yeah, no, very good.
And if you can, try and send the stones away for analysis and potentially culture as well.
Would you wait for the culture results before you place the sub?
Good question. It's meant to be the other way around though, but yeah, no, good question. I think it depends. I think you could, as long as you justify what you're recommending here, you could get marks for either of those things. So you could potentially start an empirical treatment with antibiotics here and argue that this patient is unwell and requiring emergency sub-placement or some kind of intervention. Or potentially, yeah, you could also, if you justify to the examiner that you would want to wait for that, you'd have to say why, I guess. Yeah, there's usually a bit of kind of flexibility in the marking key as well.
What about feeding it, tube feeding it? Though it probably would vomit. But the other thing that strikes me with fluids is that one kidney's pretty well had it and the other one's blocked. So I think you'd have to be a bit careful, or you might be able to kick the non-blocked kidney into action, goodness knows. But it's also going to be a lower or poorer anaesthetic risk because of its illness.
Yeah. So for this question, pretty much, yeah, every clinician will have different recommendations on how to relieve this obstruction. So there's a few different ways you could justify your primary treatment. I think the top recommendation would be a sub. So, but you could argue other things as well. Such as, I mean, things like ureteral stenting, not common in cats, but possible, and medical management you could try and justify, but I think the top answer here, in my opinion, would be a sub. And then the ongoing management you mentioned, so things like pain relief, fluid therapy, nutrition, antiemetics, appetite stimulation, that kind of stuff, just to try and support the patient through it. So talk about all of those different things as well. Just pretend you're in a clinic dealing with this kind of thing. So that's kind of, I think that was a good answer. Yeah, and antibiotics again, like that's something that's, I guess, I think you could justify either way. And in what I've written is you could, yeah, get marks for either way you justify it in this scenario. I think the important thing is here, you kind of want to say, like I've highlighted here, that you want to mention your primary treatment, then run with that and talk about how you would manage it after that. And you want to try and justify each thing quite briefly. So you don't want to go into too much detail, but you can. So don't worry too much about that. Just talk if you want to. But that's it.
By devil's advocate, there's no evidence there that there's a bacterial infection.
No, that's right. So you could say exactly that and say you would hold off and wait for the culture. You could also argue that the possibility, particularly going to surgery, maybe you would want to cover at least empirically with something. I think either way you would get marks in here in the scenario, particularly with those kind of controversial things.
Josh, sorry, at the start of this, did you say they don't show the questions and signalment and things on the screen and then they just talk to you?
No, they don't normally. So just write it down as you go. And you can always ask again. So if you miss something, just ask for it. They'll give it to you.
Okay, perfect.
Yeah, don't be afraid to ask. And you can always ask. So for example, in this question, you can say, can I go back and look at the ultrasound? Can I go back and look at the urine? That kind of stuff. You can move around as much as you want.
They want you to have all the information, so really don't feel like they're going to think you're silly if you've got to ask something. Yeah.
Honestly, like I think you can be like, can we go back to the ultrasound? Can we go back to the urine? Can we go back to the ultrasound? You can just keep going back and forth, and that's absolutely fine. The patient becomes lethargic and is notably weaker with cervical ventriflexion and is found to be bradycardic on examination. You repeat serum electrolytes as part of your plan and note that the patient's potassium has increased to 9.8 millimoles per litre. I should have put in here, this is pre-surgery or pre your primary plan while you're thinking about it. So state 2 treatment options that could reduce this patient's potassium or temporarily protect the patient, and briefly describe the mechanism of how this is achieved.
So 2 options could be calcium gluconate intravenously, which I can't quite remember the exact mechanism, but I know that it alters the threshold potential of the cardiomyocytes, and helps to counteract the effects of hyperkalemia and helps to restore the heart rate back to an appropriate level. And it's really important to monitor or auscultate the heart while you're administering this, because if you give it too rapidly or too much, it can further worsen the bradycardia or cause arrhythmias. And another option would be intravenous glucose with concurrent insulin, and that can help to drive potassium back into the cells, which would subsequently reduce your hyperkalemia, serum hyperkalemia.
Could I suggest that you should do the insulin glucose first?
Oh, sorry. Yeah, sure.
Wrong, because the calcium is sort of a last resort to just stop the hyperkalemia causing the damage that it's doing, but it doesn't do anything for the potassium levels.
Yeah, sorry, I did forget to mention that. Yeah. Thanks.
I don't think either's wrong or right. I think
Yeah,
I just give a mark for both of those.
100%. I think that was a perfect answer. So yeah, absolutely, that would be full marks there, I think.
The mechanism of the insulin glucose wasn't described.
Oh, apologies. Yep.
Remember when you're doing exams, ATBQ?
ATBQ.
Answer the bloody question.
I mean, the driving intercellular is.
It says there to explain the mechanism.
Okay. You could also talk about sodium bicarb as well here, and
Oh, yeah.
I mean, as another option, there's only 2 that's recommended here to focus on. So just focus on the ones you know in this scenario or in whatever question it is. All right, so that's the first case. Any questions on that before I move into this one? Okay, so it's a 5-year-old German Shepherd presents with a 2-week history of vomiting and or regurgitation. The owner's not sure. Has a soft cough. The owner feels that the dog is losing weight and is now lethargic and not wanting to go for walks. As part of your investigation, thoracic radiographs are taken. What is your interpretation and assessment of these radiographs? This is the first one.
I'll go if no one else wants to. It looks like there's a megaesophagus present. There's quite a lot of gas in the esophagus. The trachea looks relatively normal diameter and quite consistent throughout the length. Cardiac silhouette, without doing a vertebral heart score, it looks reasonably normal. Like there's no obvious elevation of the trachea. The vessels appear to be similar in diameter, like the pulmonary artery and vein are similar in diameter, and they don't look enlarged. I can't see any obvious masses within the thorax. And no, there's no sign of like pleural effusion or pneumothorax. Sorry, I meant to go further in assessing the changes.
If you're happy with that, that is fine.
deliberately.
Maybe ask for another view.
Yeah, there's other views. So you can ask for other views. So we've got a right lateral as well. And there's a really bad DV, sorry. Is there anything else you'd like to add after knowing that?
I don't know whether there'd be any value in asking what brand of dog food it was on. It might show a bit of extra perception behind it and thinking outside the square, but it's not part of the ATBQ. And I stress that because when I was marking students' papers, they lost tens and tens and tens of marks through not answering exactly what was asked.
So Josh, can we go back to the other lateral?
The left lateral or the right lateral?
The second one.
There you go.
Yeah, thank you.
Does anyone else keep noticing the black mark? Is that just
Oh, sorry,
an
that
artifact?
was a defect in our X-ray table.
Cool.
No, X-ray table.
just, I thought that was, but I was like, I just want to check.
Sorry, I should have mentioned that. Ignore that. It's annoying.
It looks like on the second lateral that the cranial ventral lobe has an increase in opacity. It's not as dark as I'd like it to be. So possibly some aspiration pneumonia. And the caudal lobes have an interstitial or almost bronchial pattern going on.
On the DV, it looked like there was a bit of a bronchial pattern in the caudal right lung lobe, like a bronchointerstitial pattern. I thought so anyway.
Is the cardiac silhouette sort of shifted to the left a little bit? So is that potentially just atelectasis, maybe?
Yeah, look, I think you've kind of got everything together. So I think that Eileen, I think your assessment was really good. It was just remember to ask for all the X-rays. So you just want to get all the different views and then start kind of reviewing that and interpreting what you see. The main finding here is the megaesophagus. And I think the most important thing is just make sure you have a very systematic approach to it and you're assessing everything. So it was good that you went through cardiac silhouette, pulmonary vasculature, pulmonary parenchyma, talking about whether you feel there is a bronchial pattern or alveolar, those kinds of things. If you're not right, you're not going to get deducted marks. But if you're, you just want to make sure you're assessing everything, even the skeletal changes that we don't tend to care too much about. But yeah. Okay, you diagnose megaesophagus in this patient. List your differentials for megaesophagus in this patient.
Focal myasthenia gravis, congenital, but he's 5 years old, so it would have had to be missed somehow, or as something has caused the owners to notice it more. Other acquired causes, hypothyroidism, polyradicular neuritis, but you'd expect him to be generally weak.
He does have the history of the vomiting and regurgitation, so he might be secondary to the megaesophagus might be secondary to an esophagitis maybe as well.
It could be idiopathic.
That's why I mentioned the brand of dog food, because there was a problem with one of them some years ago, 2017 or so. And I saw one in Newcastle that was from the same manufacturer, but a different type of dog food that hadn't been reported. And that went down to Melbourne for their study, but I don't know what happened since.
Okay, yeah, look, I think good differentiate between congenital and acquired megaesophagus, which you did, and all good differentials. I think this one's quite open-ended, which you might get. So some will say list a specific amount, but some will say will be quite open-ended. So just list all the things that you think it could be, but good to have for these kind of things, like a kind of split it up into things. So I guess things like obstructions are possible, but again, yeah, it's hard. I mean, this is for this patient. So I think the ones you listed for this patient are probably the right ones. But I guess you could also think things like the weird ones like hypoadrenocorticism and less likely sedation related, that kind of thing. But yeah, the ones you listed were good. Okay, list 3 additional diagnostic tests you could request to narrow down your list of differential diagnoses.
ACH receptor antibody titers. Scope, endoscopy of the esophagus.
Hydrophonium response test.
Total T4 and ACTH stim test.
Yeah, all good, all really good answers. Those first 3 answers were spot on, I think. But you could even ask for, we haven't shown you things like CBC as well here. So even those kinds of things you could ask for as well.
Yes, so correct me if others have had a different one, is that megaesophagus was extremely hard to diagnose with a scope. I could never pick them, and I've since read that others had the same experience.
I was more thinking to look for causes like strictures or circumferential foreign bodies and things like that,
Yeah,
or esophagitis.
Yeah, we have the diagnosis of megaesophagus. We're just looking for causes. So yeah, endoscopy definitely would be
well said.
I think in terms of prioritized testing, I think the total T4 is probably right up there. That I think I'd probably give 2 marks for that and then 1 mark for like tests, and like the ACH receptor antibody test, probably 2 marks as well. But then the other stuff's all kind of just the icing on the cake stuff.
Yeah, exactly. That's kind of what I had as well. Really wanted to hear I think you always should be testing for myasthenia.
And hydrophonium response test, what do you see with megaesophagus?
Pretty hard to interpret, isn't it? Like,
Yeah.
you'd have to feed them, and I guess if they're intermittently regurgitating, it's kind of hard to tell because it's focal.
Yeah, exactly. So with generalized myasthenia, it's a great test, but I don't really do it with megaesophagus because you can't assess the results really.
Yeah, I put it really in the history. I made it quite vague that the dog didn't want to go to the park type stuff or something like that. So it's going to be hard to assess, I think.
Would you say neurological exam? Just to see if it's got other weakness?
Good question. I didn't put that on there, but maybe you'd get us some marks for that, I think. All right. So you proceed to endoscopy. And as part of your next stage of diagnostic testing, and identify a very severe distal esophageal circumferential esophagitis. You're unlikely to get an image. I just thought it would be interesting. What is the primary concern with this kind of lesion?
Necrosis and risk of esophageal rupture.
Stricture formation.
Yeah, they're the 2 I had. Stricture probably top marks, and I'd say, but then yeah, necrosis is another one. I think they're the 2 I had. Cool. That's that's it, I think. In this one as well, you might, like, I don't think they would give you much to do with endoscopy to interpret, but they might give you something like this and say, describe what you see. It's another thing I was going to potentially ask, but cool.
What do you think about biopsying that, Josh? Because I mean, to me, there's a neoplastic look about that. And should that be mentioned, do you think?
Not in this question. What is it? Answer the bloody question. I mean, yeah, I guess like if it was asking, you know, what would you do from here, you could, I think, argue biopsy. Cool. All right. Well, that's mine. Did you have anything to add, Anna, from those questions, or anything that jumped out? Or do you want to jump into yours?
I know, I thought the answers were all kind of complete. I think probably when we do my questions, I'm going to make one person answer the whole question rather than having like a few people in to complete the question. So I think there was a couple of times where I thought that person hasn't finished yet or hasn't finished thinking yet, and somebody else jumped in. So just as far as kind of replicating the exam situation, I'm going to try and get that to be a focus. Except that, Josh, Zoom is now not letting me share my screen.
Do I need to?
Can I email you my presentation?
Sure.
Is that all right?
Yeah, of course.
Oh.
Why is it happening? I wonder if there's a setting or something that
it says it like it. I remember this happening last time I used this computer, but like you've got to shut down and restart Zoom to change the settings, so I can't do it mid-meeting.
Sure. Yeah, no worries.
Sorry, just getting there.
Did anyone else have any other questions at all about the format?
Will they say, you know, it's worth X amount of marks, or just?
Oh, not usually. Yeah, it's a bit, you're kind of left in the dark a bit with those kinds of things. And they purposely try and ask them to be a bit open-ended a lot of the time to allow you for, I guess, like critical thinking, creativity, and that kind of thing. So yeah, so I think just look, it's hard. Just yeah, when they formulate these questions, they think really hard to try and keep it pretty clear what you need to talk about. And if you're off the track, they'll try and put you back on.
And I think the earlier questions, like the ones like generate a problem list, a lot of the time we sort of structure that first question to make sure that you've got all the information you need. Like we're asking you to consolidate all the information we've given you so far, and we're checking you've got everything you need for the next part of the question, sort of thing. And they're the easy marks. Don't miss stuff in those ones. Just really like read the question, list, describe, justify, like what is that doing third? What do I need to do here?
You lose
Josh,
marks.
that should be coming.
Yes, I do have it.
Amazing, thank you. You don't lose marks. You won't.
No, sorry, I was just going to say, yeah, do you lose marks if they ask you to, oh, is there any more that you want to add to that? Like if, let's say you're having a brain block and you haven't listed or said it as much as you could have, and they're like, oh, are you finished? Is there any more? Do they deduct points if they have to prompt you a bit?
No, not at all. No.
You just might miss out.
Yeah, sure.
And in the writtens, there's like kind of room for like a holistic sort of like, you can't just write, like, for example, when you're marking with an answer key and you sort of say, how would you manage like fate cat, for example, if you write like pimobendan, furosemide, clopidogrel, aspirin, like Fragmin, like if you write all the drugs under the sun, technically with the answer key, like you'll be correct, right? You'll get full marks. So with the like holistic kind of, if there's a question that's over 8 marks for memberships, I think it's 12 for fellowships, then they like give you room to sort of say if the like candidate contradicts themselves or does things like list things together that would be dangerous for the patient, then they don't get the marks for those ones that you would otherwise be awarded sort of thing. But with the oral, there's no room for that. It's just literally ticking boxes. So say whatever you want.
Yeah, awesome. Yeah.
Try, like, obviously don't be dangerous.
No,
Yeah, don't
no,
do
of
anything
course,
too.
yeah.
Don't do anything really rogue.
Yeah. So I think the oral exam is really like to try and tease out like if a candidate's kind of marginal or sort of like on the cusp of passing, they're kind of like, are they a solid clinician? Are they safe? Great. Like through you go. Yeah.
Yeah, and one thing that Jeff taught me actually before I did my exam was if it's an emergency case, just make sure you mention you stabilize the patient as
Yeah.
well.
Pain
Actually,
relief,
don't know. Yeah,
get pain relief. Yeah.
yeah,
Really put yourself in the clinic.
that was really good advice.
All right, let's do it. You're going to have to advance my slides. Slide, please. Sorry.
I'll try and read it.
Okay, question 1. A 2-year-old spayed female domestic long hair cat presents for evaluation of vague clinical signs of lethargy, though was eating normally. Blood tests have been done at the regular vet, revealing an ALT of 966, an AL, which was elevated reference range provided, ALP 111, and a hyperbilirubinemia at 7 times the upper end of normal. Remaining CBC and biochemistry, including total T4, were normal. First question, create a problem list for this patient.
So you've got lethargy, quite a significant increase in the ALT, say a moderate increase in ALP and a severe increase in bilirubin, which is hyperbilirubinemia. Yeah, that's all we've really got in that.
Excellent. So next question, list suggested further diagnostic investigation. So a CBC has been done, a total T4 has been done, and a full biochem has been done. And these are just the abnormalities that I've shown you.
I would perform a blood smear if they haven't already. I also go back to the owner and ask indoor, outdoor, is there any potential access to medicine, toxins, anything like that, any different foods? If they have any other animals, are they also unwell or are they appearing normal? Because if it's something in the environment, they possibly all could have had access to it. And I would definitely perform an abdominal ultrasound. And you could also consider a pancreatic lipase, probably ideally a spec feline pancreatic lipase, but if you're trying to get a quick answer in-house, would be a good starting point with the SNAP.
Excellent. Oops, sorry, I'm not going to say that. I'm a terrible examiner.
I'd probably also do a urinalysis if I'm able to get urine of this cat.
Yeah.
Looking for bilirubin in the urine, potentially bilirubin crystals.
Perfect. Excellent. So you've got everything on my answer key now, having added urine on. But if you're given a question where bloods have been done and they don't mention urine, always chuck urine on there. It's just that kind of thoroughness. And it's nice. Oh, FIV, sorry.
Always add that.
Yeah, always, yeah. And a stim test for dogs and a FIV, FELV for cats. Next slide, please. Sorry, Josh.
No, it's fine.
So an abdominal ultrasound was performed. FIV, FELV, and urinalysis and FPLI were all normal. Abdominal ultrasound was performed, showed diffusely coarse liver with a hyperechoic gallbladder wall, and the radiologist report was presumptively due to inflammation. A liver aspirate was taken and submitted for examination. Based on the biochemistry and the ultrasound findings, or all of the findings to date, provide a prioritized differential diagnosis list and describe the likely cytological findings associated with each differential.
So
I'm gonna get-
cholangiohepatitis would probably be one of my top differentials. You might have some bacteria present, depending what the underlying cause is in your cytological sample, but I definitely expect inflammatory cells such as neutrophils, and macrophages to be present. Then it's still eating, so not really concerned about hepatic lipidosis at this stage whilst it's still eating. Yeah, I'm stuck, I'm not gonna lie.
You think about, oh, I can't prompt you.
That's okay.
I'm a terrible examiner.
It's highlighting a spot for me to go study on the weekend.
Does anybody else want to jump in with another differential? One more I want on the list.
It'd be less likely, but like a lymphocytic plasmacytic cholangitis as well.
Yeah.
Like they're typically in older cats, but it's still a possibility.
I think it's a good point, and I kind of gave Samantha that point because she did mention inflammatory infiltrates in the liver. So she mentioned cholangiohepatitis, and then mentioned there may be bacteria depending on the etiology plus inflammatory cells. So it's on my list. And then you mentioned hepatic lipidosis, which I think was good to mention. And there's one more differential for acute ALT elevation and changes in cat behavior in particular in kind of young to middle-aged cat, which it just should always be on the differential list for cats.
Autosystemic shunt.
No.
Lymphoma.
Yes, lymphoma. Yeah. So you mentioned hepatic lipidosis. Describe the likely cytologic findings.
For hepatic lipidosis. So normally the hepatocytes, they're vacuolated and it's like clear, it kind of almost looks like a bubble. That's how I remember it. Because the lipid doesn't stain up. That's the main thing I remember when looking at the cytological sides for it.
Excellent. Good. And then obviously with lymphoma, we're looking for lymphocytes. The reason I wrote this question is because a lot of the differentials that cause liver enzyme elevations in cats are diagnosable by cytology. So inflammatory cells, presence of fat vacuolation in the hepatocytes, or lymphoma, most of them will exfoliate just with an FNA, as opposed to dogs where a lot of their hepatopathies require true cuts and copper quantification, blah, blah, blah. So next slide, please, Josh. Thank you. Can somebody provide a brief description of the cytological findings here? I'm not expecting a diagnosis. Obviously, you're going to get a pathologist to look at this.
There's red blood cells on both samples. Some things I know.
Right?
It looks like on that left side, I was really bad with my red cells. It's really large lymphocytes. Yeah. I always get lymphocytes carcinomas confused with lymphocytology for some reason.
Completely. So essentially, like if you're in a membership level exam and you're shown cytology, I would say there's a raft of cells that are roundish in shape, and the origin could be hepatic or lymphocytes, or but I'm not sure. I'd refer to the pathologist. What's not there?
Neutrophil.
Bile.
Good. So there's not really a really predominant inflammatory infiltrate, is there? Excellent. Next slide, please. based on your cytology, which showed, sorry, I should have put that up. No inflammatory infiltrates essentially, and those grafts of cells were just hepatocytes with some lipid vacuolation. So essentially the cytology was non-diagnostic. List further diagnostic testing you'd perform to further investigate this patient's liver enzyme elevations. For each test, describe the clinical considerations or risk factors.
You could go for a biopsy, but I definitely want to do some coags first. And obviously you have the risk of a general anesthetic as well. It's not going to tolerate that, even if it is a true biopsy, it's not going to tolerate that away. If it was in my clinic, I'd have to go to EXUP, so we don't have to cut. That would be my first test. You could also send that biopsy for culture and sensitivity, although there is no evidence for information, so I feel like you'd just be wasting their money. At least to start with.
Good.
Serum biolysis isn't going to be any use because the bilirubin's up.
Yep, good. You mentioned TrueCut versus surgery, and you mentioned sending the culture, the sample for cytology and culture and sensitivity. Histopathology, obviously.
So
Make sure you say it.
yes.
Yeah.
Okay. Make sure I say it.
And are there any particular stains that you would request?
So there's probably more of a dog thing, but I guess if you wanted to be thorough, you could make sure there's no copper going on. Potassium, I think, is one that gets requested quite a bit.
Which one, sorry?
The class, I can't remember what it stands for.
Oh, yeah, yes.
Yes.
Periodic acid shift. Yeah.
Yeah.
I don't know what it does, actually. Sorry.
Just like, I'll ask my friend that just cytopath members.
Yes. Somebody can answer that question. It's not us. You don't need to. Copper, excellent point, does happen in cats.
Okay.
Yeah. Good. So if the cytology had been consistent with hepatic lipidosis, describe a recommended treatment plan. So
the main thing with these guys is implementing enteral feeding as soon as possible. So I'd want to place an esophageal feeding tube, ideally, and you'd start by feeding 20% of the resting energy requirement, which you calculate for this cat. And then you increase it by 10% every day until you reach full resting energy requirements. And you continue tube feeding till voluntary feeding is treated again. That can take like 2 weeks sometimes. So it's possible this cat would go home with an O-tube in place. The diet you choose, you want it to be high protein. So I'd probably use something like your AD or recovery because it's also easy to blend up and put down an O-tube.
Yep.
So that's the feeding side, and then you'd also be doing supportive care. So you'd be looking at intravenous fluid therapy to correct dehydration, electrolytes if you've got things like decreased potassium, glucose supplementation if they're really low on our glucose, and you monitor those parameters frequently. So if it was low in potassium, it would be looking for potassium every 4 to 6 hours if we're supplementing. But once we're getting food into it, it should be that the potassium doesn't drop any lower because we're supplying it. Same for glucose. If it's vomiting, you institute antiemetic therapy such as Mofetin. Metoclopramide is not really great for cats because they lack the receptors, the dopamine receptors. Could consider on Dansetron if the Mofetin isn't enough. If they seem painful, like Olivia with this, like buprenorphine, you could even consider a CRI or putting a patch on. These guys, you know, they're often, you could do a cobalamin test or you could just supplement them for cobalamin straight away because at the end of the day, it's not going to hurt if you supplement them and they don't need it. It will get excreted. I'd rather not have them have low cobalamin, particularly if the owner says no, we're sending it away and you have to wait for it to come back. If there's coagulopathies, you supplement with vitamin K. If you could try some appetite stimulants such as mirtazapine, but we are tube feeding, so I'd probably just avoid them for the moment until we're back up to that full RER and we're still not wanting to eat. And I'll definitely go down the pathway of some appetite stimulants. That's what we're looking at the moment.
You smashed that. That was amazing.
You tell my mentor's been on me for it.
Yeah, totally. The only thing that I'd potentially add is with your monitoring, add phosphate in there. Do you know why?
Yes, refeeding syndrome.
Perfect. And this patient wasn't inappetent. So it's actually not in there. It's a key for this patient.
Yeah.
But if you had a patient that was inappetent, then put that on there as well. And then there's like a supplementation of vitamin E, like SAMe, taurine and carnitine would be kind of, did you mention hepatic support, Med?
No, I didn't. I always forget they exist.
Uh,
Yeah. One of the things my brain doesn't like to remember.
So SAMe, like you can't really go wrong with SAMe, and if you've got a tube in, give it. It's like only if it's going to make them like food averse or something like that I would kind of be paring back medications. And taurine and carnitine are shown to improve fat metabolism. So it just speeds up how fast the liver can actually process and excrete that fat. And they're supplemented in diabetic foods, which is an interesting option. Low carbohydrate, high protein and fat relatively, and supplemented with taurine and carnitine. So if you're tube feeding, sometimes I just use diabetic food rather than AD or recovery. But other than that, it was a perfect answer. And it was like a 85% membership mark. That was excellent. Next slide, please. Case 2. Oh, we've got 3 minutes. Quick.
Speed case.
Sorry, speed case. Yeah,
Speed
exactly.
case.
Okay, 10-year-old male pneumococcus presents with exercise intolerance, increased respiratory rate. He's tachypnic, he's got increased lung sounds, he's quiet, he's got an occasional soft cough with a terminal retch as he moves around the consult room. There's a low grade 2 out of 6 left systolic murmur present, and he's tachycardic at 140, and his pulses are synchronous but weak. What is your diagnostic plan? I'm not going to pick on anyone, but I want somebody who hasn't answered yet.
I want to say something, I just did the whole question, so I don't want to steal the question.
Anybody putting their hand up? Okay. Maya, go.
So abdominal radiographs once you've stabilized, CBC, biochem, UA, blood gas, TFAST, AFAST, SPO2, blood pressure.
Good.
Blood-
Abdominal radiographs?
Sorry.
Which radiographs? Sorry.
Thoracic radiographs. And something else I was going to mention. I forgot now. Yeah.
Is it okay if I jump in and say a heartburn test? It's just my area.
Yeah.
Okay.
And ECG as well, I guess.
ECG. Did someone say echo?
They did.
Let's do it. Thanks, Jeff. Excellent. Next slide, please, Josh. So this patient had thoracic radiographs. I'm not going to get you to describe these radiographs, actually. There's cardiomegaly. Next view, please. So you can see, can you actually see my mouth, my cursor?
Yeah.
This is mine, or
Oh, battle of the cursors. So you can see the left atrium bulging up here. So this dog's got some splenomegaly, liver looks normal in size. The rest of the radiographs look quite normal apart from profound left atriomegaly or cardiomegaly. You can see the trachea is dorsally deviated and increased density in the quarter dorsal lung fields. Next slide, please. Echocardiographic findings show left ventricular volume overload, so the internal diameter of the left ventricle is increased, and the fractional shortening is decreased at 11%, should be over 25. The echocardiographic report concluded dilated cardiomyopathy with left atriomegaly, mitral regurgitation, and congestive heart failure. Next slide, please. List additional testing or historical information you would recommend for this patient.
I think in Cocker Spaniels recommended to test taurine and ask about diet, whether they've been feeding grain-free diet or any unusual diets that might not contain, like a vegan diet or something like that, that might not contain enough taurine.
Excellent. Well done. Okay. Now you guys know how to manage heart failure. So I'm not going to get you to answer the optimal treatment plan, except that put taurine in if you're in this situation, because it does improve systolic function even in patients that aren't deficient. And what's the main drug that you want to get in ASAP?
Furosemide,
Yes. Yep. Perfect. And then the one that you'd give at the same time.
Hemobendin.
Thank you. Excellent. And that's really all you need to give. And then the rest of it's the oxygen. Don't miss the easy marks. Oxygen, sedation if they're stressed, blah, 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 hospitalization, until congestive heart failure resolves. All right, we're gonna go.
Thank you so
Sorry.
much.
Yeah,
Thanks,
thank you very
guys.
much.
Well done, everyone. It's the easy marks that will get you through this. Just take your time, take a breath, just get your problem list solid and you'll pass. And you guys, you smashed those questions. Very well done.
Totally.
And I was going to make some comments about attitude to the exam. Is that any help?
I'm sure it is. I'm so sorry. My lecture started 2 minutes ago. I gotta go. Sorry, guys.
Yeah.
Thanks, Anna. Thanks, Josh.
Thank you very much.
Thank you.
Bye.
Thank you.